Welcome everyone to our webinar titled EHS Fall Referral Program, facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman, and I am the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. And Parachute now sponsors the Fall Prevention Communities of Practice Loop and Loop Junior, along with the annual Fall Prevention Month campaign. It's 12 p.m. Eastern now, so we're going to get started, and we'll allow people to join the line as they become available. But before we begin, we'd like to start today's presentation with a land acknowledgement. So today we respectfully acknowledge the land on which we live and work as the traditional, ancestral, and unceded territory of the Indigenous peoples of Canada's First Nations, Inuit and Métis people, whose presence reaches back to ancestral time. We respect and affirm the inherent rights and the title of Indigenous people of Canada and declare our respect of Indigenous elders, past, present, and future. I would ask that everyone just takes a moment to themselves to acknowledge the land where they currently reside and where they're joining us today. Next, I just want to cover a few housekeeping items. During the webinar, if you have questions about the technology, please type them into the chat box. My colleague Marguerite will be monitoring this. And if you have questions for our presenter about the webinar content, please submit those through the Q&A box. And you'll see that at the bottom of your screen, the Q&A box there. These are all going to be addressed at the end of the webinar, and you'll be able to view questions that you have asked, but not questions posed by other participants. The webinar is being recorded, and a YouTube link will be sent to all participants in about 1 week, and also access to the presentation slides. And you can view previous webinar recordings by simply heading over to our YouTube channel or by going to Loop and clicking on archive webinars from the webinars page. But with all that, I'm going to now introduce our presenter, Francine Butts. Francine is a support specialist within Emergency Health Services Integrated Health Care Program's portfolio. She is an advanced care paramedic by trade and has worked in various frontline clinical leadership and operational leadership roles over the course of her career. For a complete bio on Francine, please take a look at the Zoom invitation or check out the Loop event calendar. But without further ado, please take it away, Francine, and you can start sharing your screen.
Wonderful, thank you.
No problem.
All right, so Michelle, do you just confirm me you actually see my presentation?
I do. We are seeing, though, the editor view. I don't know if when we tested it out a couple minutes ago, we were only seeing the slide view. I don't know if, yeah, maybe try it again and we'll see what we get. Perfect. And yeah, just seeing the slides now.
Okay, that's wonderful. Thank you. And thanks for your patience today, everyone. And certainly thanks for the invite. I'm very thankful to be here today and to talk a little bit about this wonderful partnership that we have with our falls prevention team here in Nova Scotia. So as Michelle had alluded to, my name is Francine Butts and I work for Emergency Health Services Nova Scotia, and certainly I'm a paramedic by trade. But one of I think the important aspects just to note about paramedicine is while we focus on acute care medicine, we also focus on chronic disease and health promotion and prevention and chronic disease management and really patient safety and trying to advocate for all the great and wonderful things to help make our patients and the healthcare system just a little bit better. And that's one of the, I think, integral aspects of this particular program is, we took emergency health services, which, primarily does focus on acute care. But then we really worked on how do we partner and collaborate with other, healthcare partners in the healthcare system to better support our patients in the community. So over the course of the next few slides, I am certainly going to just focus on that key particular partnership between Emergency Health Services Nova Scotia and the falls prevention team within our communities. So to get us started here, a little myth-busting. So fact or fiction? A call to 911 and an ambulance responding lights and sirens equals a trip to the hospital. I would say that is fiction, of course, but it is a common perception in the community. So you often see an ambulance responding to a 911 call with its lights and sirens going. And sometimes that's based on the information that's coming into the EHS Medical Communication Center. So our call takers are vetting those calls as they're coming in through the 911 system, but they may not get all of the information that should be provided to them. So whoever is on the other end of the phone may not be disclosing all of the information, or it may not be overly clear. There may be some language barriers, or it could just be the clinical context that warrants that 911 lights and sirens response. And so we really try to focus on how do we best approach each patient in the community. So you'll often see an ambulance responding, but that doesn't equate to an ambulance transport for every single patient. And over the course of the next few slides, I'm going to speak specifically to some of those myth-busting concepts, but then also some of the aspects where EHS really focuses on capacity and patients. I would say risk mitigation, number one, but then how do we connect with other partners in our community to be more holistic in our patients' care? So again, it is not uncommon for any patient to refuse EHS transport after calling 911. And like any other professions, patients seen in the 911 system have the right to refuse assessment, treatment, and transport. Patients who do decline transport into the hospital or remain home after calling 911 are some of our highest risk calls. On a daily basis, our clinicians must find a balance between protecting the patient from harm and providing appropriate care, and respecting the patient's right to their own decisions. It certainly is difficult in the pre-hospital setting and typically hinges on whether the patient possesses decision-making capacity and the right to refuse care and treatment transport. The assessment of capacity in the pre-hospital setting is certainly challenging, but we try to focus on 4 key areas, and we refer to this as the ACC. So looking at autonomy, does the patient have the legal right to make their own decisions? And if they don't, is there a a substitute decision maker? Are they close by? Do they have community supports? Is it somebody that's able to support the patient or advocate on their behalf? When we look at comprehension, we really focus the patient on the clinical situation. And again, this is information that you folks, would follow as well. In the pre-hospital setting, it's important for us to really sit down in the moment and have those thoughtful and meaningful conversations with the patient to ensure that they truly understand what has happened to them and what are some of those risks and consequences of them not being treated and or transported. So if EHS was going into a home after, and we've identified some patient safety risk factors, it's important for us to take the time to sit down with the patient in their environment and really disclose those risks and consequences of not being treated or transported, and ensuring that they can relay that information back to us and that they have a strong understanding of what that potentially means for them. At the end of the day, it certainly becomes challenging when we do identify these risks, and there are further options for these patients. So if we are identifying these patient safety risks in the home, whether it is secondary to a fall or it's some other risk factors, and again, the patient is demonstrating decision-making capacity, and we've gone through our ACDC steps. It's been nerve-wracking for an EHS clinician to then have to leave the patient at home. So it's really important for us to have this partnership with our falls preventions team here in Nova Scotia, so that we have this opportunity when we do identify a fall risk or a potential for a future fall, to have that collaboration and partnership with true professionals in that realm, that we can do that continuity and handover of care to have some follow-up in the home. So it's certainly of great benefit to the EHS profession and to our paramedic. Are feeling quite bad. They've gone through these assessments, they've identified these risks, they try to have these conversations and relay this information to the patient. And at the end of the day, they're still refusing. It's really valuable and important for the EHS clinician to know that they have this partnership. And so I'm going to talk about that partnership here in the next few minutes. So we do have an ability for an EHS clinician to make a referral to a couple of areas in our province where we have community falls prevention programs. The catch at this moment in time is the entire Western region, and in the Northern region, it would be Truro, Milford, and Tanamagouche. So if an ambulance was responding to a fall related, they went in the home, they identify concerns, they would talk to the patient, go through their AC again, and then decide, okay, what is the next best course of action? Or who could we refer this individual to have follow-up care with? There's always the family physician. So you think about the primary care aspect. Maybe it's a local walk-in clinic, or there's another community resource that we can potentially call 811 and have them connected in that particular stream. Those are all wonderful resources, and we would certainly continue to advocate for those for the patient and promote and prompt. But I do think, when we talk about identifying these falls related risks and the potential to, again, have this continuity of care with the great folks at the falls prevention team here in Nova Scotia, it just further solidifies that we can have that one continuity of care and improve the overall health system in these particular communities that truly need it the most. So again, it's the entire Western region, and then the Truro, Milford, and Tanamagouche communities in the Northern region. We'd certainly like to expand and will any opportunity to partner and collaborate. So if you're certainly in a community where you think that this particular service might benefit, the residents of your community, certainly let us know if you're here in Nova Scotia. But certainly if you're looking to collaborate with another EMS organization across the country, it's certainly, strongly promote that. I think that a lot of the times, not having the number on hand, but a lot of the times in EMS, you do get 911 calls for those falls, and they just need a lift. They need a lift back into bed, they need a lift back on their couch. But they're, as you folks all know, right, that's secondary to the reason of their fall. And so when we go in and we identify the reason, it's important for the right folks to go in and spend some meaningful time in the home environment, department making those recommendations and making those adjustments. So certainly, our partnership here in Nova Scotia is it's worth its weight in gold. So I'd certainly recommend, again, if you have not partnered with an EMS organization, I would certainly strongly recommend it. And then the role of EHS, I just want to recap just a little bit. So when there is a patient in the community that is identified to have a falls risk factor, or certainly has a potential for future falls, so look for clinical frailty or such just the bothered environment, certainly the EHS clinician will then go through a couple of different steps. So we've identified the risk, it's weighing heavily on our shoulders, and now we'll sit down and talk to the patient about what are those potential next steps. So looking at health pathways. And so, yes, I did mention, contacting primary care or a local clinic, other community support groups, 811, all great options in resourcing. But again, there's this beautiful program and partnership between EHS and the falls prevention team here in Nova Scotia. So we'll sit down with the patient or substitute decision maker, and we'll talk about the program. And we'll talk about the process about submitting a referral to the program and having the team member come out into the home and really sit down and go through some of those risks and make those recommendations. So once we obtain verbal consent, our EHS clinicians in the home will then call our medical communication center again. I have another program, which is called the Clinical Support Desk, and those particular staff members help to navigate these referrals. So they too play an integral role in taking the information from the street and moving it into a referral process to our falls prevention team. So they truly are the conduit for that information sharing. So they too are paramedics by trade. And so they'll take the information over the radio. They will fill out a referral form, which I'll show you here in just a second. And then that referral form and what we refer to as our patient care record will be sent off to the falls prevention team where the patient currently resides. So it'll go directly back, to their community. So again, they're an integral role. There's a couple of different players here, but certainly it is an important role. For data collection and retention, also having conversations on recorded lines, and then the sharing of information between healthcare partners. So the EHS referral form, this form was developed in collaboration with our local teams. And again, it's kind of, I would say, a high level information gathering on this particular referral form. But then we get into the nitty gritty of the assessment findings, any treatments that were provided, the reasoning for the patient to refuse EHS transport. Those items are captured in the patient care report. And that too will be shared with the falls prevention team. So they get a wider breadth of information. So again, the referral form is really high level. So we look at some of those indications, age plus or minus 65. And really what we're looking at here in Nova Scotia is the clinical frailty, right? So is there signs of clinical frailty? Are there other associated falls risk factors? Do we feel that this patient is at risk for a future fall? If those are indicated, then the paramedic can certainly call up the clinical support desk and advocate on the patient's behalf. This information again gets shared with the falls prevention team, and then they furthermore do their clinical vetting when they call the patient or substitute decision maker and have those discussions. And at that time, if it was a 45-year-old individual, and with the information that we provided, they felt that was out of scope of the program, they can decline services at that time. But it truly is, it truly is an opportunity for our teams to identify risk, and try to close on some of those gaps. Um, and so then I'm just going to the next slide here. So, and then again, we to our patient care record. So I just took one little snippet from our patient care record, but the patient care record can sometimes be 17 pages in length. So it's quite robust. And this is a record that's completed after every patient-provider interaction in our 911 medical system. So anytime EHS paramedics respond to a 911 call and have a patient-provider interaction, they have to fill out these patient care reports. What we have done in our last iteration of our software upgrade is we added this additional section for false reporting. So looking just a little bit deeper into the reasoning of the fall. But in addition to this, again, there's a wide breadth of information that is captured. So the electronic patient care report starts off with, lengthy comments section where the paramedics free type basically a summary of the entire interaction, so that our team has a better understanding of the environment, what was seen, what was interpreted during that initial healthcare provider to patient interaction. What were some of their concerns, again, if they provided any treatment or such. And then it will go into each of the individual body systems, and there's vital signs section. If there were some EKGs that were taken, all of that can get added to the patient care report. So again, it is quite robust, but we feel that sharing this information with our falls prevention teams is important, because then they truly have an appreciation for what the paramedics saw in the home, in the moment, after they had called 911. So again, those documents get sent off to the falls prevention team, and it goes to a secure fax in the community where the patient resides. We do have exclusion criteria. Again, we did talk about the plus minus 65. So it's a relative exclusion criteria. We really focus on the health history of the patient and how clinically frail they are, and do they have those risk factors that is going to put them at increased risk. Individuals that are transported to an emergency department are also excluded. And the reasoning for that is that those patients would be seen by other healthcare providers who would then make a referral to their falls prevention teams within their own communities or facilities. However, when the paramedic is transporting the patient to the emergency department in handover of care, we're painting the same picture. We're talking about the same risk factors. What was identified in the home? What are we concerned or worried about? And then we're also prompting or promoting, advocating for that referral into the falls prevention team. The same information is captured on their patient care record, whether they were transported or not. So in the advocacy section, we're still advocating for the patient to refer to the falls prevention team. Individuals living in long-term care facilities are also excluded. Primarily due to the supports that they do have in the home. And of course, they're at increased risk 100%, but they do have more services than those living outside the home. So they are excluded at this moment in time. And then of course, individuals living outside our catchment areas. And we've done some research, lots of advocating to expand across the province, and certainly we're hopeful that we'll get there at some point. There's a lot of added value to having this partnership. So we look forward to opportunities for future growth and development. The Falls Referral Program is also not intended to replace addiction, adult protection, or mental health services. And to date, I am unaware of any issues or concerns with any of our referrals to date. Our referral numbers, so just looking at the past year. Now, the past year has been a bit of a different roller coaster for everybody, that is for sure. But I did want to talk about the last year in particular, because of our roller coaster, how vulnerable our patient population is when we talk about falls referral programs. And the fact that they have primarily lived in isolation in their communities for a large portion of the last 12 months. I think it's important for us to note that EHS submitted 76 referrals in those communities alone. And that means 76 patients had follow-up with the falls prevention team. And, I think that's certainly celebratory in a time where I think that they really needed it the most. Those numbers are certainly combined referral locations. So that would be, again, the entire Western region and the Truro, Milford, and Township areas. So that concludes my presentation and introduction into our partnership and collaborative approach between EHS and the Nova Scotia Falls Prevention Program. Are there any questions?
Thank you, Francine. So if anyone has any questions, please feel free to put them in the chat box. I'll share a couple of housekeeping items. I'll share my screen quickly. And share screen. But I do, before we get into the closing housekeeping items, I do want to thank you, Francine, for that really informative and engaging presentation. It's great to see a truly integrated program. And so, yeah, really enjoyed listening about that program. So I'll let people add any questions that they might have into the chat box, and we can address these momentarily. But I just want to remind everyone that when the webinar has ended, you will be redirected to Zoom and invited to participate in a short evaluation survey. So please fill that out. We really appreciate any feedback that you can provide. And I see we've got a couple of questions popping up in the Q&A box. So I'll just open up those. So the first question is, when a resident refuses transport to acute care, are they charged for an ambulance call?
No, they're not. So it's a great question, and I thank you for asking that. But no, they are not. They are not charged for their ambulance call. So they have the ability to be assessed and certainly advocated for care follow-up and alternative care pathways, but they are not charged for their ambulance call.
Great, thank you for that. And the next question is, are you aware of other EHS fall referral programs in Canada?
I'm currently not aware at this moment in time of other referral programs, unfortunately.
Thank you. That actually kind of goes nicely with a question I had, Francine. I was wondering if you might speak to kind of the biggest challenge you see associated with this program, just for those who might be on the webinar and thinking they'd like to integrate a program like this to their jurisdiction or wherever they are in the country. So wondering what kind of challenges you see implementing this kind of program.
I think we've been very fortunate here in Nova Scotia. So my challenges are going to be probably a little bit different than in other jurisdictions. So in Nova Scotia, we have a team that really wants to be patient advocates and do the best that they can with their partnership and their collaboration. So when we collaborated on starting this particular initiative, it was all about how do we overcome those barriers and how do we overcome overcome those challenges, and probably not accepting no for an answer on both sides. So that was the beauty of it. We both wanted to do this for the right reasons. And I started my presentation talking about the risks that come with a 911 call. Because there's nothing that weighs heavier on the shoulders or the heart of a paramedic is when you go in and you identify these individuals that are clinically frail and have these risk factors. And, you spend a lot of time sitting there trying to advocate for their safety and making sure that they truly understand, the reasonings for their falls or some of the clinical aspects that we've identified and, and the outcomes. And then to have a patient that has demonstrated capacity and saying, yes, I fully understand that, I'm still not going. It certainly heavily a paramedic's heart and sleeve. And so then they have to leave thinking, oh goodness, what if something else happens to them? Did I advocate enough? And so when you have this program, you say, okay, there is going to be continuity of care. They are going to get, care from the right provider at the right time. A potential barrier for people could be the amount of time that EHS goes in and then the follow-up. Is there a delay in the follow-up? Again, here in Nova Scotia, I can't say anything ill about our teams. They are just excellent. So they go in within a day or two, they've contacted the patient, their substitute decision-making, they're having those conversations, they're booking the follow-ups, they're going into the home, and then they send me an email and they say, we received your referral on such and such date. Our team went into the home. I just wanted you to know that. And so for patient privacy, concerns, we can't share too much information, but by them providing me that information, I sent an email back to the paramedics that responded to that initial call and saying things are going to be okay. You identify these concerns, you took the time to talk to the patient about the program, we submitted the referral on your behalf, and guess what? They were out within a day or two. So I think that's kind of, again, the beauty of this partnership, but how lucky we are here in Nova Scotia to have teams that are so engaged. The only challenge that I currently see here in Nova Scotia is that we still have communities that we don't have that partnership with yet. So we're going to continue to work on that. And it's not because they don't see the value of partnering with EHS. There are some other community options in the community that, they're partnering with. But, hopefully we will expand and continue to grow. But certainly, I think we're very lucky here in Nova Scotia, but partnership number one, and then the loop closure back to your primary providers is also key.
Great. Thanks for that. That was super informative. I'll follow up kind of our question about awareness of any other similar programs in Canada that one of the participants shared that Alberta has a referral process. It is an all hazards approach that links our navigators with needed community services. So thank you for sharing that intel from Alberta. Also wanted to just remind folks that if you do want to speak, you can always raise your hand and I can unmute you, and then you can join in the conversation that way. Otherwise, feel free to put your questions or comments in the Q&A box. So we're going to move on to the next question. Rhonda says, we have tried unsuccessfully to develop a partnership with FIRE. Too many competing priorities. And she's wondering if you have any suggestions around that.
Yeah, that's certainly a challenge, when people do have competing priorities, especially now with staffing challenges and such. I'm not sure if your fire service is linked to the EMS organization in your community. but linking with the EMS service may be a good option for you. Again, only because of those items that I disclosed in my first couple of slides, right? So when they're identifying these risks through their comprehensive assessments, they're really trying to think about patient pathways. What is the safest option for me to hand over care to the next most appropriate person for my patient? So the right care for the right patient at the right time. And your fire service, again, may be linked with EMS, and that is their focus, but their focus may not be on the clinical aspects too. You might, specifically be on fire calls. So it's really community dependent, and the types of services that either your fire department or the EMS in collaboration provide. But again, if you haven't approached the EMS organization in your community, that would be my suggestion, is to start there.
Fair enough. Our next question is there involvement by community paramedics in follow-up?
That's a great question. Thank you for asking it. So I am the supervisor for an integrated healthcare programs portfolio, and I have a number of programs in that portfolio, and one of them is a community paramedic program. I currently do not have the community paramedic program offered in this community, but if I did, I 100% could see a partnership there as well. Again, I think it always goes back to the right patient and the right resource at the right time. And I think that's an important concept for us all to really think about as we navigate through our patients and our healthcare needs. And so I think that there's a role for, the 911 emergency response, maybe some virtual care aspects, community paramedic, but also, the RPT and OT teams, right? So really linking the right patients to the right providers in the right time is always key. But the community paramedic program itself is just a beautiful program, and I really do wish that we could take it right across this country, because there's so much extra value in the services that they can provide as well. Here in Nova Scotia, we currently have one in what's called Cape Breton Island. And then we have a subset of that particular program in the Halifax Region Municipality, which is not too far from where we offer our falls prevention referral program, but we're not quite in that community just yet. Hopefully soon.
Fair enough. Awesome. Thanks for that awesome question and great answer. Moving on to the next question. They ask, could you talk a little bit about the fall prevention team? Who are they? Who are they funded through? What disciplines? And they thank you so much for this important work.
Yeah, that's great questions. That is certainly out of my scope here, where I certainly reside within the EHS realm. But I know my colleague, Suzanne Baker, is on the line, and she can answer this question fairly seamless. I'm not sure if there's an opportunity for her to speak at this moment in time, but I think it would be better served if Suzanne were to speak to that one specifically.
Suzanne, if you're there, feel free to raise your hand and I can unmute you. Otherwise, we might be able to connect this question asker. Oh, I see you've raised your hand. Let me just find you in our participant list and I'll unmute you. All right, you are allowed to talk. You're just on mute right now.
Can you hear me?
We can hear you now. Thanks, Suzanne.
Okay, what was the question again, Michelle?
So they asked, could you talk a little bit about the fall prevention team? Who are they? Who are they funded through? What disciplines?
Yeah, so it's a really interdisciplinary team. It's actually, we have a couple teams actually in the western area of the province. One's called our Seniors Community Health Team, and the other one is Senior Links. They have similar disciplines. So they have OT, occupational therapy, physical therapy. They have nurse, pharmacist, social worker, and they are both connected actually to our new geriatrician that just started. So once they go in, once that team goes in, there's really no disciplines missing that I can think of. That, it's pretty inclusive. So once they go in, if they also, when they do get that referral, they go in, and if they can't make any changes, they can also go into the clinic also that's there, that's provided. So yeah, it's actually excellent. There is one area that doesn't have a seniors community health team. It's actually linked to our community OTs and PTs, and so they will go in. So it varies, but we're working on trying to have that team approach that we have has been really effective in a lot of ways. So that's yeah, that's the group.
Awesome. Thanks so much, Suzanne. That's very helpful. I love this multidisciplinary approach to our Q&A. Alrighty, so the next question, I'm just gonna mute you, Suzanne, and lower your hand for you. But the next question is, if there are more referrals than availability, how do you triage who gets timely follow-up?
Yeah, again, I think we need to take Suzanne off mute and really let her run the next couple of questions. Again, that's the beauty of this partnership and collaboration. So, yeah, Suzanne, you're up.
Yeah, I mean, we've never had any really issues in terms of follow-up. Sometimes our follow-ups aren't as quickly as what we might want. However, the people are always seen. There's always they touch base immediately with a phone call as soon as the referral comes in. But then actually getting out in the community might take a little bit longer. But yeah, we've never really had any issues that way at all that we've had to address in terms of a wait list or anything. Even like right now with COVID, I think it's really important because we are addressing the needs in the community. That way we're actually keeping people healthy and safe and out of the hospital. So our community team has been extremely busy, and I think that's one of the great benefits with it. Because it is that piece of prevention, right? We're preventing anything, and out of all the referrals that we've got, when we looked at this before, because we've done a couple of small research projects with this, and the data showed that all the people that called with a fall and then had a referral never have called back with a second fall and had to get that second referral. Whereas we've had people that maybe didn't enroll in the program and did call back again with a second fall. So we know that it's going to happen. And that's obviously part of the purpose of having the program itself.
Right. Thanks, Suzanne. The next question, I see the mention of the falls prevention team again. So we might ask you again, Suzanne, but here it is. When a referral comes in, what are the steps your fall prevention team follow to assess a person?
So when they do get a referral, and we really, in terms of calling them fall prevention team, you can call them whatever they want. I mean, they are the seniors community health team that deals specifically with seniors. When you think of occupational therapy and physiotherapy and pharmacy, I mean, they're dealing with geriatric patients, and falls, of course, are always on the top of their list, right? So, I mean, they're going in and they will do further assessments if needed. They might do, home safety. That's something that we're actually working on right now, is a home safety checklist, so that the paramedics can actually eventually, they're going to leave that checklist, and that's for the people that might not want to get referred out to the program, because we do get people that say, no, we don't want it. So this way we can sort of have something to leave in place. But they might do an assessment in terms of, a full medication review. Again, they're going to look at the home and see in terms of safety. They're going to check the person in terms of their balance and gait and any fall issues that they might have. And or if there's other things going on, because quite often these cases can be like very complex. And so I think that's one of the important things that we have to remember. So they're not always just addressing, because you have to think of falls. Falls really is so many areas. It covers so many areas, instead of just looking from the slide that Francine showed about, when you're looking at the different risk factors that are biological, behavioral, BBSE, that's all I'm remembering, of course, is with that slide. And and I mean, all of those things have to be considered. So it's, looking at that person in particular and finding out more specifically with that patient-centered care. So it's more looking at that person and figuring out exactly what they need. So whatever discipline they might need, that would be the discipline that might be focused to. Hope I answered the question.
You did great. Thank you, Suzanne. So we've got one question in the Q&A box, but we did have one in the chat box that I'm going to ask now, just so I don't forget. They were wondering what % refuse to be transported, Francine, if you know an estimate on that.
I don't, and I did kind of start down the road of really looking at our data analytics for the non-transports, but it's just a little too difficult to weed through because of the varying, complexities behind some of the non-transports. So, we really focused on the amount that were referred to the program as opposed to the actual non-transport rate, because it could be linked to many other things. So, and to really kind of hone in, were there falls related risk factors versus, I stubbed my toe and it was just stubbed my toe. No other risk factors. It's really hard to weed through that data in our electronic reporting system. So no, I didn't, unfortunately, and I don't have those statistics for you.
No worries. Alrighty, so we'll head into our last question. They ask, I presume this program is quite new. Are there any statistics that reflect on a reduction in the incidence of falls?
I'll speak to it a little bit, and then of course, Suzanne, you feel free to jump on in here. This is certainly your area of expertise. From an EHS EMS standpoint, it is a little more challenging for us to be able to comment on this because we don't have access to the overall health history of a patient. So we're looking at the incidences where EHS was directly involved with the patient. So unfortunately, I don't have the statistics that would reflect that from an overall health history standpoint. And I know that, Suzanne and our team, we've talked about that a lot, about how do we capture that data and look at those outcomes and those key performance indicators, right? Because that's where you really see the impact in the service. And unfortunately, at this moment in time, I do not have the statistics. The conversations are ongoing, though, for sure. Especially where we really want to continue to promote this program, and we do a lot of education with Suzanne and her team. Where we actually get her team and Suzanne most of the times to come and talk to our paramedics and talk about specific cases or opportunities for improvement or just promotion. Really just promoting the referral program. So at this moment in time, I do not have any statistics to share unless Suzanne does.
Alrighty. I don't know if Suzanne has anything to add. She's currently muted, but I do see that Marguerite has her hand up. So Marguerite, you can unmute yourself. If you're not able to, let me know and I can. Oh, there you go.
Thank you, Michelle, and certainly thank you, Francine. I am the consultant liaison for the Fall Prevention Community of Practice, and I live in beautiful Huron County in Ontario. We had a program which was very similar. It was called Lift Assist, and with COVID and the person retiring, I'm not sure what the current status is, but I wanted to share a couple things. And one is that the percentage of people who refused transport was really quite high. They were happy to just be lifted up and put back in the chair. I don't have that in front of me, so I can't quote it exactly, but it really was quite high. And then people were referred and they did things very similar to what you did. One of the things that we worked on here, which I would be very happy to share, and I can be reached through Loop, people can email me there, is that we work together, the person in charge, myself, and our home and community support services. And we put together a handout for anybody who's volunteering, like Meals on Wheels or Friendly Visitor. If they come in and they find someone who has fallen, the steps that they can take. And I would be very happy to share that as a template if anybody wanted to adapt it to their own practice. And thank you, Francine. I'm really happy to hear your presentation, and keep up the good work, you and Suzanne and everybody who is doing everything to prevent falls. Thank you.
So thank you for sharing that. That means a lot. You know, we talk about the lift assist. That's certainly a common request in the EHS system. So yes, that would be great if you could share that information. Thank you.
Great. Thank you, Marguerite. And Liz, I see your question, so I'll track that you'd love to have that. Oh, and I see Marguerite is typing an answer for you, so we'll make sure that you get that as well. But unless there are any other questions, we may be able to adjourn our meeting. Oh, something just came into the chat box related to an earlier question. So we had Brian noted that I would imagine the qualitative data speaks for itself, which is a good point. And then Steen replied, I agree, Brian, we had the same issues with data. Quantitative data is very difficult, and we had to rely heavily on qualitative info. Ultimately, we realized we could only really measure the linkages to services, but we could not demonstrate a clear line of sight to reduction data because of the complexity of healthcare. That's a common problem, complexity of healthcare.
Yeah. The one patient, one record would certainly help mitigate that, but I think we're a long ways away from that, unfortunately. Yeah.
Absolutely. All righty. Well, unless anyone has anything else to add, we'll wrap up and give you a few minutes of your afternoon back. I want to thank you again, Francine. This was a really informative presentation, and the discussion has been really engaging. So thank you to our participants for all of those really valuable questions. Please remember to fill out the evaluation survey, and look forward to an email in your inbox with the recording in a few days, and access to this slide. So thank you again, and I hope everyone has a wonderful afternoon.
Thank you. Take care, everyone.